Hi. Hi. Today we are going to learn about psoriasis, and that's the session 2 of my dermatology series. So, psoriasis is a complex immune mediated inflammatory disease that occurs mostly in genetically susceptible individuals. And earlier the onset, more severe the disease would be. Psoriasis is one of the diseases which follows a bimodal age distribution. That means it's most commonly occurs around the age of 18 to 39 years and around 50 to 69 years. Both genetic and environmental factors have an influence on the age of onset of the psoriasis. Psoriasis, like most of the time, common people have this notion that it's contagious, but it's some condition that is not contagious. But it also often have like a family history. Some of the medications can also cause psoriasis, such as beta blockers, lithium, and antimalarials. The other differential diagnosis that we usually go for a psoriasis patient would be pityriasis rosea, lichen planus, mycosis fungoides, PLEV, which means pityriasis lichenoides viriliformis acuta, and plaque psoriasis. So all these conditions can be considered when a patient comes with psoriasis, just to rule out. The clinical features of the psoriasis is most commonly seen as sharply demarcated dull red plaques, and it usually have silvery scales which shed easily. And most variants of the psoriasis have basically three features, which is erythema, thickening, and scaling. And the areas are always well demarcated and it's always symmetric. So the clinical features, like I mentioned, they have like well demarcated plaques with some silvery scales, and the causal factors could be genetic predisposition, stress, skin trauma, behavioral factors, any other medications, and infections. All of these, which can cause some immune dysfunction, and this can trigger the attacks of psoriasis. Subtypes of psoriasis include plaque psoriasis, guttate psoriasis, erythrodermic psoriasis, pustular psoriasis, palmoplantar psoriasis. Plaque psoriasis is the most common variant and it affects up to around 80% of the patient with psoriasis. It usually appears as sharply demarcated, raised patches of inflamed, itchy, and painful skin with scales, silvery white scales. The skin may be red with silvery white scales, or it can look more purple. It usually depends on the skin type and color of the individual. Most often, it appears on the extensors, knees, and elbows, and it can also appear on scalp, around the belly button, and lower back. So this is the picture of a individual with plaque psoriasis, which shows like well demarcated symmetrical lesions, which is really thick and with silvery scales. The next one is guttate psoriasis. It's less common. It's only like 8% of the people with psoriasis. And the clinical features usually include like small red spots, and this is caused by inflammation. And usually occurs on the arms, legs, and the torso. It can clear by its own even without treatment. It usually takes around like 3 to 4 months and it gets cleared. Sometimes the streptococcal infection can trigger guttate psoriasis. Pityriasis rosea and pityriasis lichenoides chronica, they should be considered as differential diagnosis for a patient who has a similar presentation. But in those cases, they won't have a throat infection by streptococcus beforehand. In most of the cases, guttate psoriasis will have a beforehand a streptococcal infection. So you can always ask about throat infection when you see this picture just to reach the diagnosis. The next one is erythrodermic psoriasis. It's really rare, usually occurs only in like 2% of the people, and the clinical features include intense redness and shedding of skin layers in large sheets. And this can result in severe itching and pain, changes in heart rate and temperature due to the shedding of the skin and loss of water, and the patient can get dehydrated. And it can also come with some nail changes. And the site is almost all the time, it occurs all over the whole body and it's life threatening. So the patient will need admission to the hospitals and will need IV fluid hydration. Pustular psoriasis is the other variant. It occurs only about in 3% of the people, and the clinical features include small pustules that may be surrounded by inflamed and red skin. It usually occurs in hands and feet, just like palmoplandular pustulosis, or it can sometimes cover most of the body, but usually it's hands and feet. The location of the psoriasis can vary. It can be on the scalp, or sometimes people can develop facial psoriasis, and it can be on the extensor, knees, and elbows. It can occur on skin folds, hands, feet, just like we told now, pustular psoriasis, and also in the genital area psoriasis. So, another variant of the psoriasis based on the location is nail psoriasis, which normally affects several digits and is more common on the fingernails rather than. So, nail psoriasis usually affects the digits and most commonly the fingernails than the tall nails. Pain and tenderness from the nail psoriasis can usually impact almost all the daily activities. Nail psoriasis is usually an indicator of psoriatic arthritis. The most common nail problems include pitting, which means holes in the. One second. So, like I was saying, the most common nail problems are pitting, which is holes in the nails, and deformation, that is, there is some alterations in the normal shape of the nail, And there could be thickening of the nail. Onycholysis means separation of the nail from the nail bed, and discoloration of the nail. It can become more yellowish in color, yellow brown. The next one is scalp psoriasis, which usually affects the scalp, hairline, back of the neck, and skin around the ears. Mostly seen in around 45 to 56% of the patients with psoriasis. And there is thick scale over well defined red thickened skin, and the scale is usually silvery white. Psoriasis sometimes it can extend beyond the hairline, and that can become facial psoriasis. And the most common symptom is itching, and this itching and scratching can sometimes lead to scalp bleeds. Psoriatic arthritis. So, like we said, if there is any nail psoriasis, it's like a predisposing factor to psoriatic arthritis. And 30% of the people with psoriasis can have psoriatic arthritis. So, chronic inflammatory disease of the joints and where tendons and ligaments connect to the bone, that's called psoriatic arthritis. It can affect in any age, and in some cases, it can even affect children. It usually occurs between 30 and 50. For many people, it starts about 10 years after psoriasis develops, but sometimes there are cases where psoriatic arthritis is developed first without even or ever developing psoriasis at all. In most of the cases, if a person is having psoriatic arthritis, they will have an elevated ESR and CRP. Then there is another psoriasis called inverse psoriasis, which is usually seen in one fourth of the people. And there is inflamed deep red skin, which is that is smooth and not scaly. So, like we said, as we learn now, the psoriasis is usually defined as thickened skin with red scale, like silvery white scales. But in inverse psoriasis, it's just the opposite. It's just deep red skin, which is smooth and not scaly. And it usually affects the skin folds such as underarms, under breast, and in the genital area and buttocks, whereas the other psoriasis usually occurs on the extensor surface. And this can cause severe itching and pain, and it usually get worsened by sweat, and especially underarms and genital areas, they usually get worsened because of sweat and by rubbing on those areas. The diagnosis of psoriasis, we have two main signs. First one is called Auspit sign. So when we lift the scale off from the plaque, we can see pinpoint bleeding, and that sign is called Auspit sign. And there is a phenomena called Kobner phenomena, where new psoriatic lesions they actually develop at the site of trauma, which can be due to scratching, any cuts, pressure, or sunburn. There are two other conditions in dermatology which shows the same phenomena, which is called lichen planus and vitiligo. The parameters that we usually use to assess the severity of the psoriasis is the extent or the body surface area that's affected, the amount of erythema, thickness of the skin, and desquamation. There is a scale called PASI, which is psoriasis area and severity index, which is a measure of the overall psoriasis severity and coverage. And this consists of two major steps, which is calculating the PSA, which means the body surface area that's covered with the lesion, and assessment of the severity of the lesion based on how much indurated it is, how much erythema it has, and on desquamation. So, if a PASI score is more than 10, then we classify it as moderate to severe disease. And based on the body surface area, if it's less than 3%, it is mild psoriasis. If it's 3 to 10%, it's moderate. And more than 10, it's severe. The complications that can be associated with psoriasis include neurologic complications like reactive depression, higher suicidal ideation because it affects mental health of the patient, alcoholism. Ophthalmic complications can be ocular inflammations like iritis, uveitis, and episcleritis. Metabolic complications like arterial hypertension, dyslipidemia, insulin resistant diabetes, obesity, and increased cardiovascular risk. And Rheumatic complications, like we said, it can cause psoriatic arthritis and spondyloarthropathies. Gastrointestinal complications that can come along with psoriasis include Crohn's and ulcerative colitis. And other dermatological complications depends on the site and type of the psoriasis, which is plaque psoriasis, generalized psoriasis, palmoplantar psoriasis, nail psoriasis, etc. So here I have just shown a picture of the steroids, which can be classified based on their strength. So we usually start with mild steroids, which is hydrocortisone 1%, and moderate include betamethasone 0.025 and clobetasone 0.05. And one of the potent steroid is betnovate cream, which contains betamethasone 0.1%. And very potent is a dermavate cream, which has clobetasol propionate, that is 0.05%. We also have steroids combined with antibiotics, ointments, which can be used in cases of infections. The topical treatment for scalp include Diprosalic scalp application, which we have to do once to twice daily for 2 weeks, or ointments like Dovabet or 5% LPC in betnovate. And along with it, we can sometimes use cocois ointment, which we have to leave in for a few hours and then we have to wash it out. And this is repeated twice per week. And these are the treatment options for a scalp psoriasis. Scalp being thicker, we can go for a higher strength steroids. Topical treatments for body include we can use topical steroids, tacrolimus, coal-tar, calcipotriol, and any combinations such as calcipotriol with betamethasone. And these are commonly used and most effective in plaque psoriasis. Usually, we start with one and then we can add on other topical agents. If the topical steroid treatment is not becoming effective, we have to get a dermatology doctor opinion and we have to consider systemic and biologic therapy. In cases of extensive plaque psoriasis, we can try phototherapy or we can try systemic agents which include methotrexate, acitretin, cyclosporin, mycophenolate, or we can go for biologic therapies which include TNF alpha, interleukin 12, 23, interleukin 17, interleukin 23 inhibitors like adalimumab and everything. And another general factor that we have to consider for the management of psoriasis is avoidance of triggers, which include avoid scratching, extensive combing, pulling of the scales, and avoid smoking. There have been studies going on to see if there is any direct correlation with smoking and psoriasis. Preventing recurrence, we have to space the usage of the topical steroid to twice per week in order to reduce the side effects. And as a maintenance, we can use topical calcineurin inhibitors like tacrolimus. But then in that case, we just have to be aware of the irritation. And when we give a treatment, an acceptable treatment response is either body surface area less than or 3%, or an improvement in the body surface area of more than 7% from baseline 3 months after the initiation of the treatment. Ideally, we target for the treatment response to be BSA, body surface area involvement less than 1% 3 months after the initiation of treatment, and which is maintained at every 6 months assessment interval during the maintenance therapy with calcineurin inhibitors. And we can also assess whether the minimal response has been met with a particular treatment regime. That means for a minimal response, a 50% or more reduction in baseline disease severity is needed, and in clinically relevant improvement in physical, psychological, or social functioning. That is more than 4-point improvement in DLQI or resolution of low mood. So DLQI is Dermatology Life Quality Index. So it usually helps us to know how much a skin problem is affecting an individual based on their mental health and psychologically. So it lists a few questions and we can give the form to the patient to answer. And with that, we can actually calculate how much impact the particular condition is having on his life. So a DLQI, the minimum score is 0 and the maximum is 30. And if it's more than 10, it indicates that the patient's life is being really severely affected by the skin disease. So in that cases, we can also think about referring the patient for psychological support or any psychiatric doctors. And then there is another scoring tool called Psoriasis Epidemiology Screening Tool, which helps us to score and the chances of developing psoriatic arthritis. So a total score of three or more out of five, and that means it's positive. So we would have to refer the patient to the rheumatology to rule out the psoriatic arthritis. So that's a quick recap on the psoriasis. If you have any questions, you can pop them in the chat box, or you can scan the QR code or follow the link to give feedback and get your certificates. Thank you.